And we've just developed some new guidelines for the emergency department in the hospital. So hopefully by the end of this, you'll kind of see what all we've changed, what the goals of it, evidence we have for making those changes. So I'm a pediatric headache specialist and a child neurologist. I've been here for about a year and a half. I came from UCSF, and before that I was in Minnesota at Mayo Clinic. So I've seen how different hospitals do it, and hopefully we can kind of mesh it all into one good working system. So I don't have any relevant financial disclosures. A lot of the medicines we talk about are off-label, but that's because a lot of pediatric studies are not really done. They just try to extrapolate adult data. So it doesn't mean that it's unsafe per se. And it's still quarantine again. So this is, of course, from Groundhog Day. I do want to, on a serious note, say I really appreciate all the people that are in the hospital day in and day out and making those sacrifices. So thank you. So our learning objectives are to understand the pathophysiology of migraine, talk about how we diagnose it, what red flags do we look for in our evaluations that make us worry about something else going on. We'll talk about acute treatments of migraine and what might be contraindications for those treatments. And then we'll finally look at some safe and easy preventive treatments that can help people with their migraine pattern. In our Dell Children's Headache Program, we have been expanding pretty rapidly since I got here. This wasn't something that really existed before. So we just got a Pediatric Headache Fellowship approved. And the reason we did that is there's only about 20 pediatric headache doctors in the country. And so the only way to have more is to train more. And we're also, with COVID, it increased our ability to do telehealth. So that's been something we're doing pretty frequently now. We do clinical research. We're involved in clinical trials. We have a huge database of patients that we kind of look for data and associations. We have recently hired nurse practitioners, so that will help us expand our ability to see more patients. We have pediatric pain psychologists, and so you can imagine with chronic pain and the disability that comes with that we're looking for approaches to treatment that are not just medications. And of course, we have social work, and for those people that are wanting to refer friends, family, or just patients from the hospital, that's our referral number. So why is it important to talk about migraine education? It's over 1 billion people have migraine. And we know it's the second leading cause of years lost due to disability. It can happen in about 1/5 of all adolescents. In people 15 to 49, so a pretty otherwise young and healthy population. As far as socioeconomic status, adolescents with a household income of less than $22,000 per year have a migraine prevalence nearly double that of adolescents in a household that makes more than $90,000 per year. So it does affect, unfortunately, a part of society that already has enough strain. And as we discussed, there's very few headache specialists, so education for the general public that's really in contact with patients more often, I think, is key. And then, funding from the NIH is pretty low compared to how much disability headache causes. So I think through education and this kind of outreach, that will help. So migraine diagnosis, there's going to be a lot of words on the screen, but it's really not too hard to make a diagnosis of migraine. I think a lot of times adults who have migraine or have observed migraine and they see the people vomiting and the lights out, that's pretty easy to spot migraine. But in young people, migraine might be a bit more subtle. They might not have that vomiting problem. They may not need a pitch dark room. And so the symptoms sometimes can be more mild, and that might throw people off and say it must be something else. So when we're talking to people, it's important to know that, young people tend to underexpress their symptoms. Maybe they don't want to seem like complainers. Maybe they don't think about it that much, but it's important to ask. So they might say, oh, it's like twice a month. But if you just ask them the question, how often do you have even a small headache? They'll say, well, every day. But they don't mention that from the beginning. So in pediatric migraine, the headaches can last anywhere from a couple of hours to several days. And they'll have these characteristics. Now, the part I've underlined is more related to pediatrics than adults. In adults, both sides, in the front generally, it can be throbbing. It's usually pretty intense pain. And they feel like moving around and doing activities makes it worse. And then you can get nauseated from it. And then the sensitivity to light and sound in young children can be inferred from their behavior. So even in kids that are 3 and 4 years old that I see with migraines, you can get a good sense of these characteristics if you take the time to ask. And migraine with aura, this happens in about a quarter to a third of all people with migraine. I think it's important to know that a lot of times aura can be kind of a mystifying process to people, and they might just call it complex migraine. But complex migraine is not really a diagnosis. It leaves a lot of ambiguity. So let me explain what an aura is, first of all. An aura is when you get neurologic symptoms that usually come over the course of a few minutes and might last up to an hour or so. And then around that time, they get a bad migraine. So this is something that's usually happened more than once. It's usually happened more than twice. And it usually happens with their worst migraines. So the most common version of this is visual aura. So you see people that talk about enlarging spots in both eyes, and sometimes they sparkle, sometimes there's zigzag lines, sometimes like this picture example, there's a little worm, some sort of curvy line. So that's something that will get worse over time. And then sensory, this can sometimes make people nervous. So they say, okay, well, I have reduced sensation in my hand or in my arm. And so, of course, most people in the ER think, well, is this either a migraine or is it a stroke? So it's important to ask, how did the symptoms come on? You know, with aura, it's going to come on over a few minutes. Of course, with stroke, it's going to hit instantly, typically. So I think that's a really important distinguishing feature that needs to be asked. And when you think about speech, so if you have people that have word finding difficulties when they're in a lot of pain, that's not a language aura, but it's more like the stroke-like poor language that you would associate with aura. Motor aura is not too uncommon, actually. What's what we call hemiplegic migraine. And so what you have is someone that has a bad migraine and they say they have a hard time lifting their right arm. I don't mean just generalized weakness everywhere. They just feel fatigued. That's not a motor aura. I'm talking about someone with a facial droop and can't lift the right arm. That's a motor aura. Of course, the first time it happens, you have to make sure it's not a stroke and you're going to image them. But let's say it's someone that's had this happen, 3-4 times a year for the past couple of years and they've been imaged. You can be pretty safe and certain this is a hemiplegic migraine. And brainstem aura is a bit less common. It's when you have some altered mental status. And of course, you have to think of other things the first time this happens. Retinal's pretty rare. We'll skip that part. I think it's important to kind of understand, how do we get an aura, because then all these symptoms will make a lot more sense. So if you have somebody that is having a visual aura, vision is processed in the back of the head in the occipital lobe. So what you're having is a discharge of neurons when they shouldn't be discharging. And that's how you cause the brain to have that dysfunction in the area that's processing vision. If you're having a sensory aura, you're having that same neuronal discharge in the area that controls the hand in the sensory part of the brain. Motor is the same thing. So it is a really neurologic phenomenon that can be explained. So when I'm seeing patients, we talked about how migraine is very common. And so if you have someone with regular migraine, no red flag features that we'll talk about, you don't need an MRI, because that's too many people that would be getting MRIs unnecessarily. And we know that MRIs are expensive. When I was at UCSF, a brain MRI without contrast was $10,000. So we really need to be a little bit judicious when we're ordering those tests. And sometimes you find incidental things that have nothing to do with headaches and have been there their whole life, and just cause increased anxiety for no reason that doesn't need to be followed again. So I've kind of divided imaging indications into two separate areas. So there's absolute and relative. So if someone has a headache that comes on like a light switch, we call that a thunderclap headache. That happens in people when they're having, it could be with stroke, it could be with a brain bleed. So those people definitely need imaging. If they're having other neurologic problems with their headache, like a seizure, I think most people would know that's probably not migraine. Focal neurologic deficits, papilledema. So that means when we look at the back of the eye and we see optic disc edema, signs of increased pressure, that needs imaging, and probably an LP if the imaging is normal. Positional headaches. So this is going to be if someone says, as soon as I stand up, it feels terrible, and as soon as I lie flat, it feels much better. Or if they say, when I lie flat, my head is killing me and I have to prop up on 3 pillows. Again, that makes us think there must be some sort of volume problem or pressure problem. Relative, believe it or not, I have a lot of people with migraine that say their headaches awaken them from sleep, and I image a lot of them and their imaging is normal. So I think it goes into what other factors are going on that make us decide whether we image for that. Headaches change over time. So just in the fact that it might change from 2 days a week to 4 days a week doesn't mean they need an MRI. It really depends on, okay, well, it's finals week, or there's been some stress in the family. There's certain high-risk populations that probably get imaged to be more conservative. So people with sickle cell, people with malignancy, people with immunodeficiencies, they tend to get imaged more often. New daily persistent headaches. So this is a phenomenon where people say, I had this headache develop on this specific day, and it was out of the blue, no good reason for it, and it's been around for 4 or 5 months and nothing has helped. So that's kind of a subset of migraine that's pretty annoying, as you could imagine, and we typically do image those people. Young patients can get migraine, so I think the age limit really doesn't matter to me personally, but I think if you're making broad criteria, of course, migraine is a bit less common in very young children, so something to keep in mind. And then we talked about side-locked headaches. So if you're an adult with a headache just on the right frontal area, that's pretty normal. But a kid with only on the right side, that's a bit atypical. So it has to be taken a part of the whole picture. Okay, so pathophysiology. I won't bore you with a ton of details, but there is a lot of misconception about what causes migraine. Not the triggers, but what's the cause. So migraine is a brain disorder. We used to think that dilation of blood vessels in the head caused the migraine pain. Well, they took adults and they imaged them during a migraine, and before, during, and after, and they didn't find that dilation of arteries was actually happening. And so when they treat the migraines in the same study, they found that the vessels in the head didn't change size, but their migraine got better. So there's a lot more evidence that we'll get into, but clearly it doesn't seem to be what we thought it was. And also when people talk about, well, it must be related to arteries because my head is throbbing with my migraines. And so, when they took people that said that and they checked their heart rate and had them tap out how often the throbbing happens with their migraine, they're not in sync at all. Some are much different. So that's probably not it either. So what is actually the cause of migraine? It essentially is someone that has this genetic predisposition to changes in their lifestyle, or they get some sort of stimulus, and that triggers the release of pain chemicals. One of them is called CGRP. So everybody has CGRP, it's a protein, but people with migraine just genetically have too much of it. And so it becomes elevated and released when they have certain triggers. And if you take people that have migraine and you infuse this chemical to them, they will get a migraine. But people that don't have migraine histories, when you infuse this chemical, they don't get a migraine. So there has to be that predisposition to this chemical. And we know that treatment of migraines reduces that chemical. And we know that people that are getting migraine treatments, if they have this chemical elevated in the blood, they're more likely to respond to migraine treatment. So you would, I'm thinking, well, do we check this? We don't check it. This is more of a research thing. I'm sure we will in the future, though. So I think this is an interesting slide because it shows that, migraine is not just a headache. And I think anyone that has migraine will tell you that. There's different phases of a migraine. And so we go from a premonitory phase, which means you have an awareness that a migraine is coming on before the pain starts. We have the aura that we talked about a quarter of all people with migraine. We have the headache phase, which is the obvious part of it. And then the postdrome, which means you just get kind of tired and wiped out. Even after the pain is gone, you can't do that much. So they took people with migraine and analyzed their brain function and activity during these phases. And they found that different parts of the brain are hyperactive, meaning probably causing the symptoms leading to in those phases. So you can imagine with your premonitory phase, you have all these symptoms. You don't feel good, you're irritable, you're sensitive to things. That's actually coming from a part of the brain that regulates all that stuff called the hypothalamus. So the thing about migraine is it's not that straightforward, of course. There's not one gene that causes migraine. There's a bunch of different genes that can be altered that have been shown to be associated with migraine. We don't do those tests traditionally unless you have hemiplegic migraine because those are known genetic causes. So you have somebody with this genetic predisposition to migraine, you take in environmental factors like the spring allergy season for some people, you take into account comorbidities like depression or anxiety, and then let's say prior pain experiences if they have some PTSD related to some prior pain problem, hormonal changes. We know that prior to puberty, boys and girls get migraine about in the same frequency, but after puberty, young women get migraine, are 3 times more likely to have migraine. And certain lifestyle factors. So you take the other options that can contribute to migraine is if you get bad sleep and you feel, you don't drink enough water and you skip breakfast and lunch because you don't have time. And there's certain medications we'll talk about that can worsen your migraine pattern. So you take all those things into account, and that kind of is the reason you end up with a migraine, and some people have it more than others. So let's talk about acute treatment principles. So there's acute treatment when I feel bad, I want something. There's preemptive treatment. I have an illness, I want to kind of knock this down so it's not as big of a problem. And then preventive treatment. So a lot of people that I see in clinic for the first time for their headaches, they usually follow this first part here. What they do is they say, okay, I have a terrible migraine, but I'm going to try a couple Tylenol and see how that goes. And then if that doesn't work, I might try something else. And if that doesn't work, I might try something else. But what they're doing is allowing that problem to sort of build up and get worse. So you want to catch a migraine early and kind of hit it hard with the appropriate treatment so that it doesn't just sit there and smolder and get worse and worse. So when we talk to people about when to treat, we say, as soon as it's going to be more than just I need to sit down and drink water headache, you need to get your medicines ready. We know that if vomiting happens pretty soon with a migraine, pills are probably not going to be a great option. You may consider other treatments that have like a nasal spray that might help. And how often to try. Some people might try a pill once and they said it didn't work and they give up on it. But we have to tell people you got to try it for a few different migraine attacks to see its benefit. Triggers. So everyone has an opinion about triggers. I try to go through a big list of triggers with everybody on their first visit. Stress, but actually in adults, letdown from stress is a more common migraine trigger. So finals week happens, people are kind of managing to get through all their tests, they've been sleep deprived and drinking too much caffeine and all that. And then Saturday hits, they're relaxing, they get their worst migraine. So that's actually pretty common. With menstrual cycles, about 2 out of 3 women have worsening of their migraine during their menstrual cycle. A lot of people say, well, can I just be on birth control? And would that help? It's hit or miss. It's not reliable. In fact, some birth control can make headaches more worse. So it's not a treatment I typically go for. Exercise, some people do have a flare up, but I think sometimes it's also more related just to getting overheated and dehydration. Exercise has been shown when you do it regularly to help you have fewer headaches. So I don't discourage that at all. We know that skipping meals can trigger headaches. We know that changes in sleep schedule can trigger headaches. So Monday is the most common migraine day in young people. So that might be related to a number of factors, but probably the change in the sleep schedule. Weather change, some people before it rains or they notice their migraines happen. Eye strain, you would think that this would really cause a lot of people's headaches. I mean, it probably does, but we're all forced to look at screens all the time. I don't notice that people are saying all of a sudden it's much worse. And a lot of people say, well, I got new glasses, my headaches are still the same. Maybe I have a selection bias. People come see me if that doesn't work. And then seasonal allergies, I think, can be, of course, a trigger, but not as much as you think. So other contributing factors other than the birth control we talked about, stimulants. A lot of people, unfortunately, are on stimulants during the school year, and that's also a time when they're more stressed and also a time where they're getting less sleep. So stimulants probably do contribute to headaches, but also it's multifactorial. I don't discourage people from using, drinking a soda once a day, but if they're trying to chase their headaches with caffeine and more caffeine, it's just going to build a tolerance, and then it's going to be causing its own headaches. A lot of people wonder if gluten has something to do with it. Unless you have celiac disease, it probably doesn't. They've actually looked at sugar and chocolate in studies, and it's not been a consistent trigger to say it's definitely a trigger. Of course, some people are sure of it, and I don't try to talk them out of that. Medication overuse will go into detail, but there are certain medications that treat pain, as you might expect, that can cause headaches. And then just helping people understand that if you have migraine, you're going to have migraines. There's not a magic cure that gets rid of it forever necessarily. Some people outgrow them, but just setting the right expectations. So thinking about medication overuse headache, this is something I see very commonly. Certain treatments that are given for pain, as you imagine, if you have a headache every single day, you feel, I'm sure, inclined to want to take a pain pill to reduce that so that you can at least function during the day, but unknowingly you're causing more of the problem. So different medications have more sensitivity to causing that problem. You have people, if they come in with taking ibuprofen or Tylenol every day, those non-specific analgesics, and all I do is get people to stop those and that they have fewer headaches by quite a lot. I typically tell people to avoid combination pills. I guess I can take Excedrin off here. I heard it's pulled off the shelves. So, but the reason I say don't take combination pills is because people don't know what's in them, and they may be doubling up with a different over-the-counter medication. And in one study of people with chronic migraine, which means you have headaches more days than not, almost half of them were overusing medication. So the most commonly overused things are ibuprofen and Tylenol, probably because it seems pretty safe because they're over the counter. And the consequences of overusing these medicines, other than too many headaches, it can cause dependence. It can cause your preventive treatments to not work as well. Of course, they can damage your organs like your kidney and your liver, depending on what you're taking. And a lot of times just educating people to avoid this problem is enough. But also I try not to give people huge supplies of medication so that they don't have to see me but every year. I try to keep a regular follow-up with people. So what acute medication options do we have? I know I've been talking a lot and we haven't really gotten to the guidelines, which I'm sure you guys are interested in hearing about, but I think it was important to build the foundation so that you can understand why the guidelines say what they say. So triptans will be in the guidelines. Triptans have been around for a couple of decades now. They block the release of CGRP, which is that pain chemical we talked about. And there's different routes that we can give it. There's pills, there's dissolvable medications, there's nasal sprays, there's injectables. And because they increase serotonin temporarily, they can cause some flushing or tightness in the jaw and the chest. Some people can feel a little nauseated from it. We don't give it to people with any vascular problems because it can cause a vasoconstriction. A lot of people have thought in the past that it can cause a serotonin syndrome. It doesn't. So it's okay to use it with antidepressants. It's okay to use it with aura. It doesn't increase your stroke risk. And unfortunately, there was one large study, and they saw that only 10% of people with chronic migraine are ever prescribed triptans, which was the first, medications designed to treat migraine acutely. So very commonly, I tell people, if you kind of have a more mild headache, you can take, whatever you want to take. But if it's a bad migraine, I typically tell people to take a triptan with naproxen. I like naproxen. It's a long-acting NSAID. It doesn't cause the rebound headache problem that you can get with ibuprofen. And so when they looked at adult studies of this, they found that using both of these together worked better than using either one of them alone. And when they used the same combination in teenagers, they found that it worked pretty well and that it was very well tolerated without significant side effects. Of course, naproxen being an NSAID, you want to make sure that you have some food in your stomach if possible to prevent any GI upset. And a common problem is that, if you're taking medications enough to where you're causing a medication overuse headache, you can't really just stop those medicines and feel good. You're going to feel bad. So I use naproxen to help people kind of bridge to where they're off those medicines and back functioning relatively normal, and then we can kind of stop it and use naproxen as needed. So sometimes when people travel, they tend to get more headaches because of the flight or the time zone change. It's okay to use this for up to a week to kind of mitigate some of that. Sometimes with menstrual cycle, migraine flares up, you can use it during those times. And it works pretty well. The American Academy of Neurology made this huge document. It was like 170 pages talking about how do we treat migraine acutely in pediatrics. And I'll spare you reading it all, but this were like the final 10 points I distilled down. Again, this is just for your general knowledge. It's important that they wanted doctors to get a specific headache type diagnosed, like migraine. Make sure you take a good history, tell them to take the medications early in an attack, prescribe the general standard treatments, trial different medicines if needed, balance, sort of weigh your pros and cons of different medicines, give anti-nausea medications, counsel them on their lifestyle factors, and talk about medication overuse. Okay, so here are the guidelines that we came up with. I believe they're probably somewhere on the intranet there. They're about 20 pages long, but I'll try to summarize these parts of it. So in the emergency department, the evidence we have for the guidelines we're going to talk about is, there's actually not been any randomized controlled trials comparing a treatment to placebo for the standard migraine cocktail. I know that's surprising, but one of the two good studies we have on this for prochlorperazine or compazine is when you give it to people IV, 94% of people in one study found at least a 50% benefit. About a third of those patients developed akathisia, which is this restless leg feeling, but that is temporary. In very rare cases, especially more likely if you give repeated doses, you can develop a dystonic reaction, which is very uncomfortable. You get the muscles that are tight and you might get sweaty, be in a lot of pain. And that usually happens when people are getting too much compazine too often. So our standard migraine cocktail in most places is compazine, ketorolac, which is Toradol, and then IV fluids. Prochlorperazine is in a category of medications that also includes metoclopramide, which is Reglan. And we found that compazine is actually much more effective than Reglan for headache relief, especially compared to placebo. That was an adult study. And then looking at magnesium, a lot of people use magnesium, and I'm sure it does work for some people, but when they looked at several different studies and combined and pulled the results, we had almost 300 patients, and they failed to show benefit compared to placebo in treating migraine in the emergency department. They also, a lot of times people will give steroids for migraine management. It's never been shown to be helpful in children. It doesn't mean you should never use it. I just haven't believed that there's any research to support it. And in adults, it would take 10 patients being treated with steroids to reduce the recurrence of that headache within 2 to 3 days. So of course, steroids are not without any risks. So when we look at our algorithm that just came out this month, we have a patient, they present with a headache. We make sure that they're not pregnant or no pregnancy potential. We move on to assessing their history, doing an exam, making sure that they have a primary headache problem. And then we stratify those patients into either the mild category or the moderate to severe category. And of course, you guys are familiar with this FACES pain rating scale. We put some exclusion criteria or red flags for the patients coming with headaches to know whether they should be on the pathway or off the pathway. And this is pretty much what I talked about earlier. You know, if you have an abnormal exam, if they're very young, if you're just not sure it's a slam dunk migraine and it might need further workup, you probably want to be off this pathway. We also talked about imaging here just as a kind of pearl. I know a lot of people get head CTs, and there is sometimes an head CT, like if you think there's a head bleed or it's hard to get an MRI, you might need anesthesia, it's not available. But in general, all things being equal, if you can get an MRI, that would be preferred over a CT if there are some red flag features. I generally don't recommend giving any steroids. I recommend avoiding opioids or barbiturates. Those have been shown to really not be helpful in pediatric migraine. So let's take this piece by piece. We have the mild headache presentation, people that really haven't tried much at home other than maybe Tylenol a few hours ago. We say try naproxen or ibuprofen, so an NSAID. And then if pain is more moderate, you can pair that with sumatriptan. And then we reassess them. If they're doing better, we send them home with naproxen, like we talked about the bridge, doing that for 3 days, getting them referred to our group. And then, don't do NSAIDs if they've got like a history of GI bleeds or significant kidney dysfunction. And we also put all the medications and the doses on this protocol as well.
Dr. Qubty,
yes.
I have a quick question. This is Cheryl Kiefer, the nurse navigator.
Yes.
I am curious about when it says discharge with naproxen BID for 3 days, what's the typical turnaround time that just, I know we're still building our program and as a goal, like what would be the a recommended turnaround time for those appointments to be set?
Oh, that's a good question. I think probably following with their primary care within a week is a more realistic. I'm sure that we're already telling them to do that, but sort of in addition to that, the neuro referral will be placed and that probably gets done within, I'm guessing, 1 to 2 weeks. I believe that's what our wait is about right now, which is pretty good.
Okay, because we're looking at those bounce backs from the ED for headaches.
Uh-huh.
And so, I was just curious about what that follow-up should look like.
Yeah, so I think primary care is going to have should be involved with this and be able to give them more close follow-up. But also, this is part of the guideline is that we know that good guidelines actually help people not be admitted to the hospital after treatment and also prevent these bounce backs. And so hopefully by developing a standardized protocol with good education to all the groups, this should be less of a problem. And then we can make sure that we're putting the right follow-up in place after. And that's something that we'll be looking at, probably comparing pre-protocol to post-protocol and seeing how we can optimize it.
Great, thank you so much.
Mm-hmm. So more people are coming in with moderate to severe headaches than the mild headaches. And so a lot of the treatments we use for migraine can affect the QT interval. And so anyone with a personal family history of arrhythmia, we go ahead and check an ECG. And then we can administer the standard migraine protocol after that if all things are normal. We talked about, a lot of people have been asking about COVID and ibuprofen, and there's a couple of studies actually, and I put the PubMed IDs at the bottom there of the slide, but that was more speculative than confirmed, and based on what we now know, that shouldn't really be a contraindication. So people with COVID and having headaches, and if they're getting worse migraines, they should be treated just the same in this case, assuming their imaging is normal. So we reassess where people are at, and then I think this is the important part of the protocol that probably varies from other protocols. I like to use IV valproic acid or Depacon as sort of a second line therapy as compared to DHE in the ED, because DHE does cause a bit more nausea and is a bit less tolerated than the valproic acid. So that's my next step, assuming they're otherwise a healthy person. And then if that doesn't work, then consulting neurology. With the compazine, you can get that dystonic reaction, and so that's why we pre-treat with the diphenhydramine, which is Benadryl. And treatment of dystonic reaction is just more Benadryl. There's other treatments, but that usually works just fine. So we know that there's a proportion of patients that go through the ED and don't find benefit, or they have atypical features that warrant further workup that get admitted. And so this is a list of what other hospitals do. This is kind of more of an extensive list. We don't do most of these things, actually. I know there's a lot of interest in people using ketamine or propofol for status migrainosus, which just means a submigraine. And so not a lot of these have good evidence. The best evidence we have is actually for the dihydroergotamine, which is DHE, and the valproic acid, which we've talked about. I know in the past, I believe the hospitals used a lot of compazine, sort of Q8 hours for a couple days, but I think that causes more dystonic reaction and more problems after a couple of days. So that's why we're trying to avoid doing that as much. So when we think about the inpatient pathway, it's just like the ED pathway. You want to work them up. You want to make sure you're dealing with the primary headache problem. You want to involve child life, get the patients educated. If there's any psychologic comorbidities, having our mental health experts weigh in, treating them with the standard migraine cocktail, and the neurology is always there for backup. So if you end up admitting someone for DHE or valproic acid, depending on what it is, and assuming they get better, then there's the discharge criteria. And so you guys are probably, I think if you take a common sense approach to it and say, are you feeling well enough to leave for at least several hours so there's not going to be a bounce back, making sure that they're staying hydrated, can eat, can get up and move around, making sure they have the appropriate follow-up, making sure the medication plan has been sort of distilled and explained to people. And so we've actually updated the discharge recommendations, and we've translated to Spanish, so hopefully you'll be able to utilize that. And then next we can talk about what exactly are in these two order sets. So DHE has been around for a long, long time. It blocks that chemical that causes the migraine, and because it doesn't absorb, as in the pill form, it doesn't absorb with a good bioavailability, it's usually needing to be given either IV or IM typically. So in the past, a lot of people were just doing this for 2 or 3 days, but then a new study came out and it said, well, maybe if you do 5 days, that actually seems to work better than 2 or 3 days. And so they took a large population of adults with chronic migraine that had failed other treatments, and 2 out of the 3 patients in this study were headache-free after not have been headache-free for a long time. And even more people were headache-free the further you went out, so they weren't rebounding. Side effects during their hospitalizations, nausea is very common, leg cramps are common because DHE is a vasoconstrictor, and it vasoconstricts has receptors for it in the veins of the leg. And so that's why people are getting some of those leg cramps. It's not DVTs. And so we found that also because it's vasoconstrictive, you have to replace the peripheral IV, usually after a couple of days of DHE. And the most interesting point I want to make to you is that when they looked at who got better, they found that people that had their nausea controlled the best had the best response. So that's why it's so important that when we made this protocol revision, we made sure to address that. And so from a nursing perspective, this is more for you guys, is, it's put in 100 mils of sodium chloride. You want to monitor the blood pressure before the infusion, 10 minutes into it and immediately after. You can get hypertension with it, although in young people you can actually get hypotension, so something to be aware of. And then when people are getting these leg cramps, just making sure they're getting up and walking around to prevent that. Chest pain, anaphylaxis, nausea, those are the main things you're watching out for. I can't say that I've ever seen a case of anaphylaxis with it, and we used to do this a lot in San Francisco. And in young people, DHE can cause constipation, although on the adult side, it causes more diarrhea. Okay, so the protocol, if you have an adolescent female, you want to check the pregnancy test. You want to prehydrate. You want to pre-medicate with antiemetics. Zofran is going to be first line, or ondansetron. And then what you do is after that pre-medication and hydration, then you give a test dose of DHE. So let's say the full dose is 1 milligram. The first test dose is going to be 50% or 0.5 milligrams. And then 8 hours later, you pre-med again, and then you give the 0.75 milligrams or 75% of the dose. And then for the third dose, you give the full dose, which would be the 1 milligram. And then if they're tolerating that and it's being given over 1 hour, you tolerate that, and then you just keep on protocol. Now, this is different than the old protocol because I believe it was given over a few minutes instead of an hour. But when you push it that fast, you're going to get a ton of vomiting from people, no matter what you pre-medicate with. So going over an hour is much easier on the patient. And again, less nausea causes improved outcomes. So assuming they can tolerate this protocol, they'll usually get about 12 doses or so, but you can be treated up to 15 doses. And it's important to counsel people that you don't have to be headache free to leave the hospital. Although that's, of course, what we would love to happen, it takes time to see the full benefits, even up to a few weeks after you leave. So let's say someone is getting pre-medicated with Zofran and they're still having quite a bit of nausea and not really tolerating it that well, not eating. So what you could potentially do is add in a lower dose of compazine instead of the Zofran to see if that works better. You could potentially slow down the infusion, maybe to 2 hours. So there's some options we have to make it more tolerable to people. Okay, so then the other treatment option we would be using is IV Depacon. So it's Depakote. So don't use it in people with liver disease, pregnant, or metabolic disorders. I'm sure neurology will be guiding you on these things as well. We give a loading dose, 20 per kilo. It's just like what you would see if you had a patient in status epilepticus. And then we give a maintenance of 5 mg per kg every 8 hours for up to 3 days. And one of the main studies that did this protocol, they found 80% of people were pain-free at the time of discharge. Now, this is much more well-tolerated and much less complicated than IV DHE, so I tend to prefer this. I think DHE probably works maybe a little bit better, but this is much more well-tolerated. Okay, so preventive treatments. I know that if you guys are mostly inpatient nursing, I just want you to be familiar with a couple things. There's non-pharmacologic treatment. So that's why we work with pediatric pain psychologists, because we've had several studies that show the benefit of cognitive behavioral therapy. So you can imagine you have a lot of chronic pain and you start feeling down, and then you start feeling like nothing will help. And then you start thinking, how am I ever gonna go hang out with my friends anymore? Or I can't play soccer anymore. So you kind of start doing this downward spiral. And what they do is they help people to identify that this is a problem and how to turn it around. And so those things and new stressors don't cause more pain and sort of continue the cycle. When they took teenagers with chronic migraine and they give them amitriptyline, They also did, another group, they did the amitriptyline plus the cognitive behavioral therapy. And they found that the CBT group did much better. And in fact, 72% of the CBT group with the amitriptyline had less than 4 headache days per month at the 1-year follow-up, compared to only half of those that just did the amitriptyline. So it's something with sustained results that we can do that insurance covers that does not have any side effects. And I can't say that most of my patients, when I tell them I want them to do CBT, most teenagers are not interested in this at all, as you can imagine. So it's just going to be something that you really need to, sit down and talk with them about, and kind of, I'll do the heavy lifting. Just send them to me. I'll talk to them about it. But it's something that is really important, has been shown to work quite well. And as nursing, you have a lot of time with your patients, hopefully, and you get to talk to them about how their lifestyle can play into their headaches. A lot of people try all kinds of unusual diets, fad diets. None of those have ever been shown to reduce migraine frequency. Just generally eat right, try not to skip meals, try to drink enough water, try to exercise. Things you already know, I'm sure. Sleep varies by how much, by your age. So, of course, very young people will need much more sleep. I don't know if any teenagers are getting, the full 8 to 10 hours per night, even during the school year, but that's the goal. And then making sure they're not looking at their screens and their phones, within the hour before bed. And anxiety and depression happen in 1/4 of all people, regardless of chronic pain problems. So you can imagine if you have chronic migraine, you're going to have an increased likelihood of those things. So just making sure we address it. My first line therapy for people when they come in saying they have a lot of migraine, instead of just being reactive and saying, okay, we'll take naproxen, take ibuprofen, take Tylenol, we want to reduce the burden of the problem. And so what you probably notice, people leaving the hospital now, other than that short naproxen bridge, they're getting started on vitamin B2 or riboflavin. That has been shown to reduce how often you get migraines. Other people might use melatonin or CoQ10, magnesium. There's, again, very little evidence to support using magnesium to prevent migraines. Doesn't mean it doesn't work, there's just not good evidence for it. And there's this website, labdoor.com, that independently assesses what's in the pills, since the government and the FDA don't do that. So I give that as a resource to families to look into. And riboflavin is on Amazon, and it's about like $10 for a month's supply, or even for maybe a month and a half supply. So it's not terribly expensive. So I didn't teach you this yet, but when counseling patients about starting a new preventive, no matter what preventive headache treatment we give, how long does it typically take to see the benefit? Now, a lot of people would probably say 2 weeks, but actually in most studies, when they look at treatments, it takes about 6 to 8 weeks to start seeing benefit. I know that's depressing if you have a lot of headaches, but that's just what it is. That's how long it takes to turn around those problems. So it's just putting your patients out, and if you say, well, if you're not better in a week, that's okay. That's okay. So I just make the point to put this here is to show that these are all the different classes of medications that are available for migraine prevention. So if people come to the hospital and they say, I've tried everything and it doesn't work, no one has tried everything that's a child. I mean, there's a ton of things that are available. So there's devices, there's new treatments called these monoclonal antibodies. They're antibodies designed to target the pain chemical and sort of block them from landing on the brain and causing the migraine symptoms. So there's all kinds of new things coming out that can help. So something to be optimistic about. And so I just want to conclude by summarizing, I think the salient points is that when people come in and they're needing an acute treatment, it works better depending on how soon into the treatment, into the headache they're getting it. So someone that's had a migraine for 3 months is not going to respond to treatment as quickly and easily as potentially someone that's had it for 3 days. So it's just kind of setting those expectations, getting the history to make sure they're not overusing over-the-counter treatments, making sure that you're aware that this is our new protocol, the prochlorperazine, the ketorolac, and IV fluids, making sure we emphasize opioids are not recommended. There are certain other providers that may be prescribing it. We just want to encourage our patients to not use those. Also, people come in and they say, well, surely these years of headache can't just be related to migraine, but indeed, if it's going on that long, it most certainly is. So just saying, overworking up is not a good idea either. And then just so you kind of have some experience that there are different preventive therapies that are available and plenty of very safe, easy things that work well. And then finally, as they're going to be following up with us, keeping track of their headaches, either on a piece of paper or there's a Migraine Buddy app that makes it pretty easy to keep track of things. So I appreciate your time, and now's a good time for any questions.
We do have one from an RN on 4 South, Lucy Gonzalez. She's asking, what is cognitive behavioral therapy in a nutshell, so we can set the stage for you?
Yeah, so it is a type of talk therapy done by a psychologist that helps people so that their stress doesn't turn into pain. Is that too simple?
That's perfect, I think.
Okay, good.
Please unmute yourselves or type into the chat and we can read it to Dr. Qubty if you have any questions.
I'm going to try to pull up the chat myself, spare you the trouble. Let's see.
Dr. Iyer did make mention they agreed that they tell people to go to the PCP from the ER.
Right. Yeah, and I think the point of the neurology referral, I really don't like for my patients, wonderful place, Dr. Iyer. But it's hopefully we can, in neurology, we can get patients on the right program so they don't need to utilize those resources, something that can be managed at home. So that's another reason to ensure neurology referral.
Yeah, Dr. Cup, thanks for the talk again. This is Sujit from the ER. I just had 2 questions from the ER point of view.
Yes.
So when kids get IV valproic acid, so the kids on the right-hand side of the pathway, they failed the initial cocktail. We try the IV Depacon. What's the normal time frame that you see a response in those kids when it works? With just that first initial dose, if it's going to work, how long does it take? Yeah.
I would say that, okay, so, if you think about the pathway, you're saying for inpatient or the ED? The ED,
so
right?
kind of that kid in the ER who failed the initial cocktail, who were going to maybe give that initial dose of Depacon. Are we giving that initial dose of Depacon mainly because they're going to be coming in pretty much no matter what, and we're just trying to load them? Or is the goal that we're giving them the Depacon with the hope that maybe that one-time dose would be sufficient to get them
that's a good question.
to avoid the admission? Yeah.
I think there will be about a 50 there's a pediatric study, there's about a 50% response rate. Now, those people were not pre-treated in a sense with IV compazine and toradol and IV fluids.
Mm-hmm.
Now, those are just people that came and they were getting it for a first go, and it was about 50% response. So I suspect if you're talking about a much more refractory population that we're trying this in after they've gotten a standard migraine cocktail. So I would suspect it's probably going to be about a 30% chance that in an hour they're going to be doing much better and ready to go home. So odds are if you're at that step, you're really most likely loading so that they can just be admitted and continue the maintenance.
Okay, that's good. And then if they did, if you have that small population that did get better, are we doing them any disservice sending them home because they just got that one-time load and they didn't get the, Q8, over a prolonged period of time?
Yeah, no, that's a great question. There's really uncharted territory and room for a good research here. So that's a great question. How soon after you get better? It depends. Are we talking about someone? If we're talking about someone that's had like months and months and months of migraine, even if they feel better after that one dose, they probably should get admitted. If we're talking about someone that's had like 2 days of a bad migraine, they're probably fine.
Yeah.
Yep.
Okay, perfect. Yeah, well, and then I guess my second question from the ER point of view, just because I think we and on the ped side, we have not used triptans as often as on the adult and adolescent side.
Right.
Other than obviously the screening for pregnancy, are there are other side effects that kids experience when taking triptans that we should know about or expect?
I would say actually young children tend to have the fewest side effects from triptans. I think maybe they're just not as in tune, perhaps, but
Yeah.
they don't report as many side effects. So I would just say, if anything, you might hear that they thought the headache was worse. I
Yeah.
think that happens probably in about 2-3% of people. They take a triptan, they feel it's worse. It may be
Yeah.
that they caught it too late and the migraine was progressing without any benefit.
Yeah. Okay. Well, great. That helps. Thanks.
Of course. Great questions.
Anyone else have any questions for Dr. Qubty? All right, thank you, Dr. Qubty. That was a really great lecture. I'm going to take a moment to show everyone where to find these guidelines.
Well, I'm curious.
Really
I'll stick
quick.
around.
So this is the internet site. When you're at work, you're just going to go into clinical. You're going to go down to evidence-based practice guidelines, pediatric. Click on that. Scroll down. I don't know if you all knew we had all these fantastic guidelines. Carmen Garudo's on the call, and she is helping to keep these up to date and lovely. Right here is migraine. And these are the different ones. You can click on them, see the pathways. This is the ED pathway. And then right below is the inpatient. What gets them admitted, what gets them discharged. There's a lot of great information on these as well for these tips and tricks and facts. This one, highly recommend you all take a look at them. Familiarize yourself with this because parents do ask these questions a lot. Common triggers, things like that. What should we be properly educating them on? So those are where you can find all this new information, and it goes live today in Compass, and it's already up. It was up yesterday on eBach. So thank you, Carmen, for doing that. I'm going to launch a quick poll, and I'm going to share the CE information for those of you claiming CEs. If you could take a minute and just fill out these quick polling questions. Question 1, true or false? 15% of the population has migraine. It can start as early as 2 to 3 years of age. Feel free, click your answers. Number 2, true or false? To be diagnosed with a migraine, you must first get a head CT, brain MRI, or EEG. True or false? Number 3, true or false? Migraines are the #1 cause of disability in people ages 15 to 49 years old. All right, we're getting a good amount of answers. As soon as I hit about 15 people answering, I will give the answers out. We're at 14. Somebody else. There we go. We got 16 answers now. So the answer for number 1 is true. It can start as early as 2 to 3 years of age, which blew my mind. 15% of the population has migraine, so it's pretty common. To be diagnosed with a migraine, you must first get a head CT, brain MRI, or EEG. That is false, as Dr. Qubty said. You do not have to get these tests to be diagnosed with migraines. And then true or false, migraines are the #1 cause of disability in people ages 15 to 49, and that is true. All right, so I'm going to end that polling, and I'm going to flash on here the Q code if any of you want to take a look at that. You can put your phone up to the screen. Turn this off, and I will share the screen for getting your CEs. It's coming, I swear.
And Yanni, after this, we have a request to show how to get to that pathway again.
For sure, definitely. Let me flash this first. Everyone can get their CEs. Can see my screen, good times. There we go. Here it is. The Q code is right here on the side. Let me know if you can't see that. Make sure to put in the chat. Q code's right here on the side. And again, there's that web address. It is in the chat link. If you go to that chat link, just click on that link and then enter that code. You'll get an evaluation. As soon as you fill out that evaluation, they will send you a certificate in your email. minutes. Any other questions on the chat, Bree? Bree is my co-moderator who is following the chat.
No other questions, just a comment from Victoria Gregg saying that this will be a great resource for the ED.
Oh, great. Glad. We are recording. Sorry, Dr. Qubty, we're recording you. We'll be sending that to ER and putting it on our own site for, so it is available to other people so they can watch it.